So thanks so much for joining us to this Shifts in Healthcare webinar. And we're looking at the role of educators in what that looks like as well. So we are looking to explore the critical role that healthcare educators play in responding to the evolving needs of the NHS, and in line with what the Health Secretary Wes Streeting's vision for addressing systemic challenges have been. So he set out 3 key shifts that he says must occur within the healthcare system. So moving from treatment to prevention, from centralised to localised care, and the better use of technology as well, that digital shift. Now, I'm really conscious that we have got attendees from across the membership, which means they'll be from outside England as well. And I just want to stress that obviously all of our work is across the nations. So there will be events that respond to the interesting developments in Scotland and Wales, potentially following devolved elections. But we know that regardless of where you are in the UK or beyond, these areas are of interest because they weren't just plucked out of thin air. They do echo lots of the thoughts about the future of health and the future of healthcare education as well. So I'm really delighted that we've got some great speakers. We've got Sean Mahoney, who's an adult and mental health nursing student from the University of Exeter. We've got Dr. Nikki Wolichko, who's Associate Professor and Deputy Head of the Institute of Health and Allied Professions, School of Social Sciences at Nottingham Trent University. And hopefully in due course, we will have Professor Sharon Weldon, who's the Associate Head for Research and Knowledge Exchange, Centre Lead for Professional Workforce Development, Professor of Healthcare Simulation and Workforce Development at the University of Greenwich. So we will bring Sharon as and when we're able to. Thanks for bearing with us. And I think we've got a good starting point for her to talk about digital and maybe sometimes the opportunities, but the limitations that come with this as well. But we've got some great speakers at hand just to kick off and offer about 10 minutes their thoughts on what these key shifts are. So the first speaker that we've got lined up is Nikki, who I've just spoken through there, who is going to offer her insights around the role of healthcare education in promoting preventative care models and looking at what we can do to address that shift as well. So Nikki, hopefully the technology's okay for you on this one as well, but we should be okay to set up your presentation, and it'd be great to hear your thoughts, your experience, but also just your insights into this shift, its achievability, what the opportunities are, what those challenges are, and how we go from there as well.
Hopefully, can you see that, James?
We've got that. We've got the one with notes up as well. So I don't know whether it's
okay,
a slightly different one that we can put.
Well, bear with me 1 second, sorry.
Yeah, of course, of course. That's great. And it's lovely to see so many people join us for this. So thanks for those who are using the chat, and we'll be thinking ahead to the questions that they might want to put in as well. And look, by all means, questions, but also challenges to the 3 shifts itself, whatever your perspectives are. As always with the webinars that we do, it really isn't just about me and a panel speaking at you. It really is about our members and your experience and your thoughts too. So look forward to hearing about that. But I think we're now in a good place for Nikki to kick off with her thoughts about this. That's fine. So I think if you go to to just click the beginning of the slideshow, maybe that will...
It's tiny on my screen, that's the issue.
Oh, okay.
Hold on.
Not to worry. Okay, is that working for you, Nikki?
Is that still got the notes up?
No, it's just a presentation. So I think...
Fabulous.
So we were meant to be kicking off with Sharon talking about digital, and like I've alluded to a few times, it's interesting when we speak about the opportunities, but even today has shown that sometimes it's not quite as simple as meeting in person or us all being together with standard notes. So there's a challenge for Sharon when she does eventually hopefully join us. But in the meantime, thanks so much for bearing with us and the technology, Nikki, and look forward to hearing your expertise and thoughts on this crucial shift about prevention over cure.
Lovely, thank you very much, James. So as James said, I'm Nikki Willichko. I'm Associate Professor at Nottingham Trent University, and I work in the Institute of Health and Allied Health Professions. So the particular focus that I wanted to look at today was the shift of a treatment focus model to a more preventative care model, particularly for people with long-term conditions, and what are the challenges for us as educators in trying to embrace that. So just to provide some context to begin with, in terms of long-term conditions impose a major burden on the NHS. And just to give you some kind of context of the extent of that, we're talking more than 50% of GP visits, 65% of outpatient appointments, and 70% of hospital bed days involve people with long-term conditions. So we've obviously got an incredibly large population, not just the elderly population, but people who are of much younger demographic living and having to negotiate long-term conditions. So over 26 million people in England, and I recognise that is England-centric, have at least one long-term condition, and 10 million people have two or more. So I think in terms of education is becoming increasingly more complex. So gone are the days when we talked about one person having COPD. We usually now have people who've got multiple long-term conditions. So condition management, long-term condition management is a lot more complicated for students and for practitioners. Long-term conditions are typically managed in primary care, and I think this underlines the need for investment in primary care and general practice, and that's particularly for the most deprived areas. And one of the things that Wes Streeting has referred to is the need for more localised community-based services that can focus on prevention and early intervention. What are the challenges for us as educators? Because there are quite a few. So implementing education-based prevention it does prevent many barriers. We've got limited resources, as we know, within the NHS and healthcare services, and we've also got reduced workforce capacity. GP consultations are typically 10 minutes in length. Nurse AHP, very, very similar in terms of practice nursing. So those short appointment times make it really difficult. One of the things that the government was very keen to look at promoting is that making every contact count. Unfortunately, often our students, when they're out in practice placements, are not actually able to see that in action because that 10-minute consultation is so focused on the primary prevention that the person has actually come in with. We've also got socio-economic factors that play a big challenge. We have a number of communities that do not have the same access to the services that are available. A lot of the writing I've done previously has been around people with learning disabilities and people with mental health challenges who often bear higher long-term condition rates, and they're also less likely to engage with education programmes. It's quite ironic, really, that at a point in time when we need to be really focusing on these marginalised groups, that we've got a really large reduction in the number of learning disability nursing applications. There are a lot of HEIs now that don't offer learning disability as an option. And really that's something I think we need to really focus on. We do know that people with learning disabilities and mental health experience significantly poorer health outcomes than the general population, and they're more likely to suffer from preventable illnesses and often have higher rates of hospital admissions. And we know from publications like Death by Indifference that often people with learning disabilities don't get the treatment they need when they are admitted to mainstream services. Obviously, another priority for the government is increased digitalisation. Well, we've had a bit of an experience of that this morning. And increased digitalisation is fantastic and it opens a lot of windows, but we also need to be conscious of the fact that we may be excluding some patient groups and indeed some students when we're looking at education and learning. Coordinating education efforts across disparate NHS and social care providers is complex, so making sure that, you know, we are doing the same thing in the same places. Funding is another big challenge. Successive governments of various colours have been very reluctant to invest in preventative healthcare, mainly because they don't get short-term benefits. Preventative healthcare is a longer-term strategy. So governments of previous successions of, as I say, of different parties have been reluctant to put a lot of money often into preventative healthcare because they don't see instant results. And it may well be a different party would then be in place at that time and then would reap the rewards of the spending that they put in. The other challenge we have as educators are policy changes. So changes in government policy, which result in changes in trajectories for us in healthcare education. We've recently had issues around potentially not being able to offer level 7 apprentices. And we've got advanced clinical practitioners who, whilst I don't think are the panacea for the NHS, I think they play a very vital role in leading a lot of local community and nurse-led services and AHP services as well. The introduction for fees for students, undergraduate healthcare students, has obviously had an impact, and also workforce development funding for our post-registration students also means that we don't have that confidence and that assurity that we are going to be able to do these, to provide that education moving forward. Some of the opportunities that this creates, if we've got some momentum from the government in terms of prevention in UK health policy, that does create us with opportunities, and I think we need to look for those opportunities. The integrated care systems are now responsible for community health and can have that ability to invest more in local health services, and expanding things like community health coaches and looking at local lifestyle schemes. 40% of people with long-term conditions, there is a behavioural element to that, so it's really important that we look at that. Technology and expanding the possibilities. At NTU, we've done a lot of work with immersive technologies, so providing some real life scenarios, particularly with our paramedic and nursing students. There's virtual wards, which can play a huge role, digital therapeutics, social prescribing, and also artificial intelligence. So digital therapeutics are obviously evidence-based software that can be designed to prevent manage or treat conditions. We've got virtual wards, and I think as educators we need to be thinking about how we can get our undergraduate pre-registration students to access those kind of opportunities with virtual wards. And also make sure that we're looking at data around that and their effectiveness. COVID-19, which we all had fun with, I think in education it's fair to say, but the one opportunity that COVID-19 did help with is it promoted and accelerated remote consultations and more treatment of patients online. And again, that can be harnessed to help with long-term condition education and reminders. We need a greater educational focus on health inequalities, so that we can target and identify those groups that are at risk, and I mentioned some of those earlier. And we have an opportunity for a cultural shift, the drive for more personalised care, utilising the wider multidisciplinary team, where we're viewing patients as partners in care, as collaborators, rather than the sort of paternalistic model of health. And my last slide, just to finish really, is looking ahead for the future. To improve, there are things we need to do to improve outcomes. At the moment, much healthcare education is often centred on primary diseases. So we need to make sure that there is an emphasis on prevention and not just treatment. And we need to invest in multi-layered prevention and early intervention. So looking at primary prevention, but also secondary prevention, which involves those behavioural changes as well. We need to make sure that we are providing and that students have the confidence to be able to engage in behavioural and lifestyle coaching. So students, we need to teach them to learn to have conversations that influence patients' behaviour, and those things include motivational interviewing, coaching strategies, and culturally competent and sensitive communication. In terms of curriculum, public health and population health integration are really important. So introducing public health fundamentals earlier on in curricula, focusing on epidemiology, health promotion programmes, community health, and encouraging students to think at the population level, so trends and risks rather than just the individual level as well. Focusing on the social determinants of health, and also looking at data as well. Again, something else we've invested in at Nottingham Trent has been some digital pedagogic support to help our academic team. We've got 2 people who really can help us to try and looking at developing that. Ensuring that we have interprofessional working, which is one of the things I think is missing from the 3 things that have been looked at. So interprofessional education, where healthcare professionals learn and work collaboratively, we know that enhances the delivery of preventative care, and by understanding each other's roles and working cohesively, healthcare teams can provide comprehensive education and support to patients, leading to better management of long-term conditions. Without addressing these, it makes prevention much harder. My final point is undergraduate healthcare education needs to shift from an illness care model to a health promotion model, equipping our future practitioners to prevent disease at both individual and societal level. And I think at the moment we have that opportunity to be able to do that. Thank you.
Fantastic. Thank you so much, Nikki, and so much food for thought there as well to share. And I know that the participants who will be joining us might have their questions, so do feel free to put them in the Q&A box, and I'll pose something maybe to the both of you, and hopefully Sharon, if she's able to join us in a bit as well. But just reflecting on it, I mean, it was echoed lots of our rallying calls at the council about that join up that we need between health and education, because we can't address areas like prevention if we don't have the people in place to fulfill those roles. And we know that join up for us is not about special pleading, it's about saying we need learning disability nurses, for example. If something is not happening on the education side, it will impact the health side. So that role for join up across government, between sectors, between universities, colleges, trusts, and across regulation as well is so important. But some really great things there. Thank you, Nikki. And really interesting as well to think about the role of education and student experience, because it's a great transition really to Sean, who brings not just expertise when it comes to the conversation around that shift as set out by the Health Secretary from centralisation to a more local model, and particularly that community-based experience, but also as a student with your thoughts, your experiences, and by all means the challenges that you think are posed towards you, but also whether that's from education or whether it's from the overall system, will be great to hear about. So Sean, over to you.
Okay, yeah, thank you. Good afternoon, everybody. I'm Sean Mahoney. I'm a nursing student at the University of Exeter, and today I'd like to share 4 placement snapshots from a residential care home to the strategic team for early intervention of psychosis, community team, also known as STEP, and 2 spoke day experiences that show the power of real multidisciplinary collaboration in preventing illness. I'll close with a question I hope will stay with you. So by the end of this, I hope you'll see why every student needs both the clinical skills from care homes, nursing homes, hospitals, and the full MDT exposure of teams like the STEP team and community spoke days if we're to deliver truly localised preventative care. So I spent 6 weeks in a 40-day bed residential home as one of my clinical placements. My daily routine was medication rounds at 9 a.m., brief vital signs and skin integrity checks, and then documentation. The moment that really stuck with me was one afternoon I found, we'll call her Miss L, in the lounge. She'd finished her lunch, but her arthritis made standing for dinner excruciating. There was no nurse until the next shift, no OT until her referral went through, and I had to watch her wait. I helped her to her feet, carried her tray, and sat with her while she ate. She thanked me softly, but in her eyes, I saw resignation that this was the best our system could offer. In that moment, I felt the isolation patients face when care is siloed. The home did its best, but without an MDT on site or working more collaboratively, many needs go unmet until crisis hits. The afternoon left me thinking, if only we train students in these settings, without broader team integration, we risk graduating professionals who see isolation as normal. So to contrast that with my STEP placement, a mental health community team dedicated for early psychosis screening and management, staffed by nurses, psychiatrists, social workers, peer support coaches, and even a housing advisor, all in one room. Every morning at 8:30 a.m., the MDT gathered around Mr. D's file. He was a student in his early 20s who'd stopped taking his medications because he felt disconnected. In just a few minutes, the psychiatrist had adjusted his dose, the social worker arranged emergency housing support, the peer coach scheduled weekly check-ins, and I organised a video call with his sister. By lunch, Mr. D felt heard. By 3 weeks, he'd avoided an admission into hospital. In one room, we tackled medical, social, and emotional issues in real time, preventing crisis before it happened. He later emailed me to say it was one of the first times he'd felt heard in months. Felt hope in months, sorry. Here was the opposite of Miss L's isolation. STEP's MDT showed me how we preserve dignity and prevent admissions when every discipline's voice is valued. During one day on placement, I joined the mobile flu vaccination team running clinics in community centres and churches across Exeter's most deprived wards. I took vital signs and flagged concerns, like a gentleman with high blood pressure and limited mobility. The pharmacy student explained possible medication interactions. The public health nurse adapted her health promotion messaging on the spot, and I connected with him with our ward's community exercise group. In one 2-hour session, we delivered vaccines, identified an unmanaged chronic issue, and offered a social support solution, all as a compact community MDT. That spoke day showed me how community-based preventative care thrives when disciplines collaborate in real time, exactly the model we need more of in our training. Last month, I spent a spoke day shadowing the occupational therapists and the dietitian on our mental health ward's physical health outreach team. We visited live patients in their flats. One had a poorly arranged kitchen that made cooking healthy meals impossible. Another struggled with mobility after discharge. The OT suggested simple adaptations, grab rails, reorganized cupboards, and demonstrated adaptive utensils. Meanwhile, the dietitian taught quick, nutrient-dense meal ideas to a patient who'd lost weight. This was a mini MDT in action. OT, dietitian, and me as a nursing student, each addressing a different facet of well-being. I saw how these home interventions prevent hospital readmission and how collaboration makes visits efficient and respectful of each profession's expertise. A spoke day like this taught me that community care truly thrives when disciplines work side by side, something standard ward placements rarely offer. So one last observation on our classroom learning when we cover public health and social detriments, it's usually from a nursing only perspective. But in practice, tackling issues like housing insecurity, nutrition, or community engagement always involves pharmacy, social work, occupational therapy, and more. Embedding those voices into our public health lectures would not only mirror real MDT collaboration, it would deepen our understanding of how prevention really works. I'll leave you with this question. When did your students last experience an authentic early spoke day MDT or integrated home visit before their ward blocks? If our goal is to graduate professionals who think team first, we need those encounters from day one. Thank you. You've heard how collaboration prevented crises on my placements. I look forward to your questions and to working together to embed those MDT experiences across education.
Fantastic. Thanks, Sean. And I think maybe a nice reversal on maybe some of our webinars where the participants are just asking the questions. There's a fair question back to everyone there, so please do feel free to use the Q&A box, maybe to answer rather than to question. But your questions are very welcome. I know we've got a couple already, but please do feel free to put some in. And like I said, I think the 3 shifts are obviously a political priority when it comes to England and the priorities of the Health Secretary, but very conscious that people might want to question them. Are there other things that should be looked at? Is that the right approach? And I suppose my first question really for Nikki and Sean are really for them. Nikki touched on this a little bit to begin with, really, which is, are the 3 shifts the right ones? Are there other shifts that actually we need to have involved as well to really deliver good healthcare across England, but also for those outside England beyond? You know, are there lessons that can be learned, or is this not the right approach? And again, something that Nikki touched on, which I think is interesting, the potential for those shifts to maybe contradict each other, sometimes that digital shift. So Nikki, if you're okay to kick off with your thoughts on that, that would be great. Then Sean will come to you, and then we'll see if we've got any further questions from the audience as well.
Yeah, well, I think Sean encapsulated it perfectly, really. So the one thing that I think is missing and is of vital importance is interprofessional education and interprofessional working. And, you know, the example Sean's just given illustrates perfectly what can be achieved when we do work together. It's about the best person in the best place to provide the care, and moving away sometimes from those restrictive labels that we have. So for me, that's definitely something that's missing from Mr. Streeting's priorities. I think one of the other things I should have said and I missed really with my presentation is also about, and again, Sean brought this out when he talked, but it's about early community exposure for our students, and strengthening in the primary care and community-based services as well. So currently we often struggle to get students sometimes into GP practices, etc. And when they're there, they perhaps don't necessarily always get a particularly rounded experience. So one of the things that we've been doing at NTU is working with the University of Nottingham and the Nottinghamshire Alliance Training Hub. So we're providing students with a 5-week placement block where they can literally go rounds with all of the primary care services, district nurses, skiffon nurses, community pharmacists, and all of those kind of things, so that they actually get a really rounded view of primary care. Because I think in the past there has potentially been that sort of expectation, oh no, when you first qualify, you don't go straight into primary care, you need to consolidate, get 6 months sort of under your belt before you go into primary care. And I think that we really need to move away from that and make sure that people see the absolute diversity that community and primary care has to offer and its growing importance, and how significant the roles can be in impacting on patients as well.
It's really useful. And look, it's our job to be the voice of our members, but sometimes that's also talking back and kind of having a conversation with our members. And I know certainly from some of the visits that I've had, that concern around the diversity in career routes that people are exposed to over courses comes up. But sometimes I felt almost compelled to ask quite simple questions like, what's in your recruitment material? Because actually, if there isn't something which sets out these different routes, then sometimes it is going to be quite self-selecting. That if people look towards hospitals, for example, what images have been used, what descriptions and case studies have been used for students, when actually, as we know that if we really want to achieve what we want for healthcare in the country, we're going to need a bigger pool of students, but also that's maybe tapping into people that wouldn't have considered health and social care. But actually, if they can see examples of a career route they could go down, that's an opportunity too, let alone portfolio careers and everything like that as well.
Yeah, and just to add before you go, Sean, things like non-hospitalised placements for paramedic students, you know, as well, obviously, as being paramedics out in terms of primary care, we've now got paramedics working really successfully in GP surgeries, etc. And it's that, I think it's that exposure again to having those experiences that widens people's horizons and makes them understand that there are other opportunities.
Sean, have you got any thoughts on that? Is there anything that's missing or contradictory? Would you kind of broadly align with the Health Secretary on this, or have you got any additional things that you might add or take away for that?
I think, yeah, I would like to add that as part of integrating healthcare providers from across the board, a lot of it is focused on integrating the NHS more closely with each other. But what I found on my placement in private settings was that they were quite isolated from the NHS, and they would have to go out and send referrals, even though we've got older people with quite a lot of advanced conditions. You would just send out your one referral for one specific condition, and then that would get set out by each individual NHS team. But if we had more of a MDT integration into private settings like learning disability, residential settings, or care home settings, we could definitely help to provide more holistic care and quicker to help prevent those illnesses from progressing into worse stages. And I think that could come down to the education level as a student. I think if we were learning more as students collaboratively with different healthcare professionals, it would benefit a lot to know how to interact with these different professionals, and where we kind of hand off responsibilities or get further advice and get further expertise to kind of help provide healthcare for everyone together. And I think that would, yeah.
Useful, Sean. And again, I feel like there's this strand that keeps coming out, which is about that kind of interprofessional work, that collaboration, and perhaps one of those areas which, with the silence, shall we say, around the long-term workforce plan as was, and obviously the council's continuing to work and engage, and we have been involved in the 10-year plan, and obviously that's meant to now include some reference to what comes next with the long-term workforce plan. But I think one of the opportunities that we saw in that, what it felt like it was moving towards better kind of collaboration and a focus on wider professions and their capacity as well. And I suppose for us, we would always really be keen for that collaboration between professions, but also their status actually really being seen by everyone, that there's really important roles that each of these professions have, yes, in complementing each other, but also in their own right. And there's something for perhaps the wider system to catch up with on that too, because I know that sometimes some students will leave having been armed with a really solid education, even if they've had really great placements, and then going into practice and realizing that some of the views are still quite outdated. And actually, because of that, that's not just about, is it a nice experience? It holds back the system because actually people aren't working to the best of their abilities, and we really do need all hands to the pump on that. So look, we've got 3 questions here. I suppose before that, it's worth saying, I think, again, ironically, digital has failed Sharon, who was going to speak about the digital shift. We may well be able to revisit that at some future webinar. So thanks for bearing with us on that. But I suppose very quickly before we go on to that, it's worth me maybe offering a couple of thoughts on digital, given that we had a summit earlier in the year on this very topic, which is to say that I think that all of our members will probably be keen to look at what we can do to equip students and universities and colleges to prepare people for effectively a future-proofed, for want of a better term, approach to education, because we know that we're living in very fast-moving times. You know, AI, which was a couple of years ago drawing really rough pictures, is now fooling people regularly online. And so there are lots of things out there where we know we need to equip people to deal with it, but there are opportunities in terms of streamlining work, in terms of equipping people, but also we know there are challenges. And without being too trite, we have actually seen one of those today with Sharon not being able to join us. Sometimes an over-dependence on new technology, a review of it being a silver bullet, can sometimes make us miss the wood for the trees. And sometimes there is also just that old-fashioned person-to-person care, person-to-person education that is also hugely important. So I hope that counts as a potted view from me, at least, on digital, which is, it's great, but it's complementary. And actually we can't go beyond what we'd be really used to on that as well. So we've got a few questions here that I'll kick off with, and Nikki and Sean, if you're happy to pick up on things from your experiences, and even if it sparks a thought, it doesn't have to necessarily directly answer that, but I know that some of them might feel better suited to either of you than others. But so we've had one contribution here which says, one of the issues we find challenging is that ICBs are in very challenging situations, and that the financial shift from acute to community and prevention is stymied. Has anyone worked with their ICBs alongside the difficult shifts that may be taking place? And I suppose that's all within the context too of what we know with NHS England and a general sense of reorganisation too. So again, perhaps from an education and perspective, it would be useful, whether that's from an educator or a student's perspective. It'd be really interesting to hear your thoughts on what those gaps sometimes feel like. I don't know, Nikki, if you had any initial thoughts.
Yeah, I think greater collaborative working with the ICBs and ICSs is really important. I think the reorganisation and obviously NHS England and etc. is unsettling, and I think it leaves us in a position where we don't really know what's going to happen moving forward. So it's difficult. I think it's difficult to plan, and I think it's difficult to put anything firmly into place. As you said earlier, James, we're still waiting for the current government's sort of NHS long-term plan. And once again, we're expected within healthcare and within a healthcare education to respond quite quickly to those things when they do come out. But I would agree that the things that are happening are difficult, and it makes it difficult to know what direction to go in and what roles organisations are going to fulfil in the future. Whether they will remain very much the same or whether things will be drastically different is really hard. So I think, again, it just makes planning really difficult.
It's worth quickly saying on that as well, that we will continually be the voice for our members, and whether that's talking at a regional, kind of local level or nationally, we are making this case, which is, again, you end up boring yourself, but it's so important. That join up between education and health is crucial, and any blockage that happens for our members, whether it's something that's an immediate obstacle or, as you say, just uncertainty that makes planning difficult, will cause problems further down the line. And so we keep articulating and making that case, but it's one that I don't think we can kind of ever stop making, because at the moment it's harder, I think, than it has been for some time to look at what the future steps are to reach these shifts that are needed. Sean, any thoughts on that?
Well, I haven't had the as much experience with working with integrated care boards, but I found that on my placement with the STEP team, the Strategic Team for Early Intervention of Psychosis, they had quite different funding, a way of doing things, and they often had to link with places from completely different counties, and that was a massive hurdle that they had to do to ensure that funding was sent to the correct places to try and facilitate the care and all the extra agencies involved in care planning for those individuals. We don't hear a lot about this in our education and our lectures, but it is definitely a massive problem that happens on the front lines in the community. And I would just like to hear like some more clarity around how these structures are formed for and how like nursing students or students in general will have to face these problems going forward into our careers.
I think, you know, your experience, Sean, about, you know, actually those jumps between kind of, you know, hospital settings and community settings, and then also private and NHS, again, just speaks to that join up challenge, and that need for just more conversations to be had between all of those structures. So I think, again, it does feel like some of those, beyond the 3 shifts, some of those things that do keep emerging are the join up between professions, but also between the different bits of the same sector, but also different sectors, for us to really achieve this. And again, I think when the government came in post the 2024 election, there was lots of language about joined up government, and I suppose the council would continue to say that really the best way to deliver those 3 shifts is to have genuine joined up government. And at the moment, it's certainly not limited to this government. It's a challenge across administrations currently in the UK and in previous Westminster governments. But that challenge of join up is something that is much easier spoken about than actually done. And it does require, I think, some quite top level involvement. During the last general election, we did put out a shared letter from the council that said, whoever the Prime Minister is after the election, we need actual number 10 or Cabinet Office responsibility for this join up, because at the moment there are lots of things that will impact health, as we said, that the Health Secretary won't have that much control over, and there'll be lots of things that an Education Secretary, for example, might have a role on, or a Science Secretary, or any number of government ministers who are really crucial to this, who actually don't have an investment in the health benefits that come from that. And that's where actually you need that strong leadership at the centre of government to say, this is why it's important for the nation. And even from a hard-headed political point of view, governments will be assessed on how successful they've been on these shifts. So I think that's a crucial thing there as well. We've got something which is definitely more of a comment than a question, but I'm really not anti-comments, because I think often they can spark thoughts. So I'm going to quickly share these, and you can see we've got Sharon as well potentially joining us now. So I'm going to race through these, and then Sharon, if you've got time, hello. We will have your presentation, which we'll have just enough time for, but I'm going to quickly share this comment, if that's okay, Sharon, to give you a bit of time to catch your breath, and I hope you'll forgive us. We've already made lots of jokes about some of the digital challenges that could arise, but just a quick thought here from someone who's joined us. He said, having completed the specialist nursing practice degree for district nursing, there is a clear lack of health promotion and social determinants of health in the current nursing programme. This should underpin all nursing knowledge. Before sending students into a hospital environment, as you say, focus on preventative health. Until students get out into the community, they will not understand the inequalities in health that exist and the reason why some patients continue to end up in hospitals, which actually I think speaks to something that both of you, Nikki and Sean, have said as well. And then there was we've got a couple of other ones, and then Sharon, hopefully you're okay to kick off with your presentation. So we've also got the thought here, which is, I think, maybe an answer to some of what had been said earlier. We have moved from a community-based year one placements with teams as our provision has become more siloed. Hopefully you can move towards this approach again. The career route issued is decades old, and absolutely agree that the workforce recruitment needs to reflect the new preferred way of working, which again, I think really useful just to echo, I think, some of what's been spoken about as well. And then there's a final one here, and then we'll hand over to Sharon. Hopefully he's able to offer some thoughts on digital, which is someone that says, I think we also have the challenges of serious work-related wellbeing concerns and burnout for staff and students, and that is absolutely something which echoes what we hear from members from the council side of things, whether that's about the expectation, the regulatory overlap and the regulatory burden, the rush for placements. I think there's a real challenge there, and it's something about keeping the profession attractive for those who are in there, but also to students who might think as part of their overall career they would like to go into education and research. But actually, what can we do to set out that A, that's a route, and B, that's an attractive route at some point in their career as well? Sharon, so lovely to see you. Thanks for bearing with us.
Sorry, everything crashed, and like you say, yeah, I'm here to talk about technology and digital.
Completely fine. Are you okay to jump in then, Sharon, and just offer your thoughts then on that digital shift?
Yeah, I mean, it's a difficult one because I feel like I've missed all the conversation, so I feel like I could go off on a tangent here, and if I do, please just redirect me. I'm just going to come in with kind of my own general personal thoughts on kind of this digital shift in healthcare education particularly. And I'm probably going to start with some concerns that I have, is that the shift is all happening so quickly. How are we going to keep up? And I think part of what I'm seeing, particularly from like a education versus a practice perspective, is practice is ahead of education in a lot of ways. And we're not all, and therefore, you know, sometimes when we are trying to educate the future generation on what they're about to go into, we're not doing it with the modern methods. And I'll give examples, you know, kind of if you look at some of the NHS trusts within the UK, they're already fully digitally literate. Yet we are educating our students on paper-based systems and how we used to do things. And there's a real disconnect, which is quite concerning, that we have to be, it's quite hard for educators because we have to be ahead of the game, even if we've not been in practice for a long time. And that's where that link has to happen. And that's, for me, where things like simulation become really powerful, because that is the link there in the bridge between our traditional methods in education and what's happening in practice. But I also think there's something else fundamentally happening as well, and with AI and everything that's just being thrown at us, which is, you know, creating so many exciting opportunities. But I think what we're not reading, or it's not that we're not, I think people are, but I think maybe we're not facing it clearly, is that there is a huge shift in society and how we do things globally more generally. And that means that whereas before with education, it used to be more of an instructional method of this is how you do something, and we were a bit clearer on how things were done and everything was simpler, everything has got a lot more complex. But not just that, things are changing so quickly that what we're educating for now probably isn't really relevant as soon as people get into practice, or it's changing so quickly, so we're not able to keep them up to date like that. And I think it's more about trying to educate them on, as we do, but on principles and things, but also I think we should be making them the change makers of the future. So rather than saying the world's black and white, there's a right and wrong way, this is how you do it, we actually enable them to say, you know, you're about to go into a healthcare system that is rapidly changing. We can't predict the changes currently because of things that are coming out, you know, AI, technology, etc. And research is rapidly changing stuff, how we treat things, how we do things. But what we can do is set you up to be prepared for that, to be people who walk into a healthcare system and are able to be adaptable, to change quickly, and to feel that you have agency to make those changes, to recognize that, as especially, you know, the newer generations, as a newer generation, you might understand the world better in some perspectives than the older generation who haven't grown up. Like me, I have young children now, and I'm really concerned about how I raise young children in a world that I didn't grow up in. I don't know how to navigate things like, even though I'm up to date with digital stuff, I still feel that they are going to know it better than I am. So I think how we need to start thinking is very differently in terms of our model of healthcare education. and that technology and will play a massive role in that, but we kind of enable the new generations coming through into healthcare to utilize it more effectively so they can be change makers, they can be agile and part of this constant transformation that is happening, rather than sticking them in a system with something certain that is uncertain. And I might have gone completely off piste here. Let me know if I have, but
No, not at all, Sharon. Thank you. And it's always difficult, I think, joining any webinar and offering kind of your thoughts. And I know it's all the more jarring when it's been a challenge to join. So we're just really grateful that you were able to join us, and B, have given so many kind of coherent thoughts on some of the issues around that digital shift. We've got a few minutes left, and so I thought one thing that I asked Nikki and Sean that maybe you could answer as well is just this question about the 3 shifts. It's almost like it could be any number of shifts really. Are there any additional ones that you think complement those 3 shifts about kind of prevention into kind of over cure, that shift to kind of community and that move to digital? And within those, I suppose, within the existing ones, are there any tensions between them? Nikki picked up on something which maybe is relevant to you as well, that sometimes any digital shift risks some of the prevention work for some people that maybe aren't equipped to deal with that, whether that's in education or as patients in the community. So I'd be interested to hear some of your thoughts on that before we close.
Yeah, and that's a really good point, because I'm focusing on like the future generations of the healthcare workforce, and they're probably going to be more up to date. But actually, the people we're treating, you're absolutely right, Nikki, they are the ones who are not going to be up to date. And how do we bridge that? And I think that's where, again, we probably need to make sure we're thinking about how do we get this new world to interact with the old one and have that empathy and understanding for the differences that we're all operating in. And that's the challenge, isn't it? And that's going to require a much broader level thinking than kind of focusing on, we're very focused on sometimes I think very specific tasks and skills and all that kind of thing, when we're not maybe preparing people for these bigger holistic overviews of what we're dealing with. But yeah, it's a good point. Yeah, I hadn't been thinking about it so much from that perspective. It's a real challenge there, but then it's actually an opportunity as well, isn't it? Technology can help us in that sense as well. How do we bridge those gaps? Maybe AI's got an answer for us.
It does feel like as a society, in a way, it's so difficult with the pace of change, but every now and again you feel like, do we ever just need to stop and pause, take a deep breath and think about the societal, cultural implications of any number of these shifts, but particularly that digital one. Access to almost unlimited knowledge, but also access to just broadcasting anything that could be on record forever, and it's all in your pocket. And that's such a change for thousands of years of human existence to adapt to. And I do wonder whether there is something within that as well, whether that's everything from kind of professionalism to actual just personal care and support as well. And I suppose it's like so many of these things, it's such an interesting double-edged sword. For some people, it's a route to help with loneliness and a route to interact with healthcare that maybe they wouldn't have been able to, but for others it might be a route to real causes of problems and also a form of isolation as well. So lots to get our head around, I think, with all of these and with all of these shifts. We're coming towards the end of the time here, so I'm really grateful for everyone for sticking with us as we've had a few challenges with technology, but I think some really interesting insights. And I'd like to think actually not the end of this conversation. We're at the beginning of a parliamentary term. We're at the beginning of a government that's looking at these shifts. It will be very interesting to reflect in a few years' time, potentially as we look towards another general election, whether we feel like these shifts have been successful, whether we think they were the right shifts by the time we get to that. And it might be technology allowing a great opportunity to get back in touch with you, Nikki, Sean, Sharon, and check in and maybe see, did things pan out how we thought it would or should, and whether we think those shifts are the right ones at that point too. So it'd be interesting to hear from you potentially then, and also from others among our membership too. So thank you everyone for joining us. We've had a really great turnout, and we've also, despite some of those technology issues, actually, I think had a really good conversation about some of these challenges and opportunities. So thanks so much for joining us. And for anyone that wants to really enjoy the benefits of the digital work as well, if you've got colleagues that think would enjoy this but weren't able to make it, we will have this recorded and up on our site as well. So feel free to share that with everyone as well. So thanks so much, and hopefully see you again soon at our next webinar. Thanks all.